Welcome to the Voices of Otolaryngology podcast series, where we spotlight diverse perspectives and insights within the field of otolaryngology. I'm your host, Rahul Shah. Let's jump into it. Welcome to Voices of Otolaryngology from the OTO EXPO floor of the 129th Annual Meeting of the American Academy of Otolaryngology. It is Monday at 4 p.m. We've almost made it, Pete.
Almost there.
Almost there. You're not going to leave early. Are you leaving tomorrow? Don't answer that if you're going to leave early.
I'm leaving tomorrow.
You're leaving tomorrow. Good, good. Because the meeting is Saturday, Sunday, Monday, Tuesday.
Correct. You got to see it through.
You got to see it through. Dr. Manis, awesome to have you with this. Could you introduce yourself?
Sure. My name's Peter Manis. I am a rhinologist at the Yale School of Medicine. Been there for about 15 years. I'm also the industry consultant for the American Academy of Otolaryngology, and I also serve as our RUC advisor, doing a lot of coding reimbursement.
Okay, so I always think of the title for these talks. I never prep you. Did I prep you?
You did not, and I knew you wouldn't, so I didn't ask.
Good. RUC, what does that stand for?
Relative Value Scale Update Committee.
But RUC, RUC.
I didn't make it up.
All right, say it again. Relative
Value Scale Update Committee.
How does that impact a otolaryngologist in practice?
It impacts how much they get reimbursed. So this whole system was set up in the 90s, where codes are valued based on a relative value unit, an RVU system. And there was a realization very quickly that that needed to be updated periodically. And all of these codes are relative to each other. So there is a relative value scale update committee which updates the valuation of these codes, values new codes, things like that.
All right, so do you ever do like a fun game with your family? Well, actually, let's talk about your family.
Sure.
So your wife's the smart one.
Correct.
All right, can we call her out?
Hi, Jacqueline.
Yeah, but hi, Jacqueline who? What does she do?
No, excuse me. Jacqueline Brewer, my wife, is a comprehensive otolaryngologist in Connecticut.
Thank you. So she's our target audience. Hopefully she'll listen to us. She'll be our only listener. Okay.
I don't know if she'll listen, but
So
I'll put in a plug.
If I say parotid, can you say like how many work RVUs it is?
I can't.
Okay. Tonsil.
I looked this up recently. I think it's 4 something.
Ear tubes.
2
Maxillary antrostomy.
3 something.
This is a fun game.
Yeah, this is hard.
Okay. But so that's the work you do, right? Is that the RUC committee?
Correct.
All right. So walk me through. Pick one of those that you know off the top of your head.
Sure. So let's say maxillary antrostomy. So sinus surgery codes were revalued maybe about 5-6 years ago.
Which is extremely recent in the world, right? 5-6 years ago is like yesterday.
It really is. And so what happens is that code hit a screen that's established by the AMA. The AMA runs this whole process. And there's a variety of different screens the AMA uses to try and identify codes that need to be revalued.
Okay, so let's not get into that, but it hit a screen.
Right.
And they said, we're going to revalue it.
Yes.
And currently, maxillary antrostomy gets how many RVUs?
I think about 3, right?
3. So what happened 5 to 6 years ago when it hit the screen?
So what happens at that point is we, as an organization, have to provide a recommendation to the RUC, to this update committee.
Well, I'd say increase it.
Correct. Except we can't just say that.
Oh.
So what we need to do is send out surveys to our members, and our membership fills out the surveys that ask them, how long does this take you? How intense is it? How complex is it? And how does it compare to current codes in the fee schedule to cause to be relative?
Slow down because you're terrific. So I get an email, and I think I got this one because it asked me about a survey.
Yep.
Do I fill out the survey? Do I not fill out the survey? I got an email for that.
You absolutely should fill out the survey. So because your answers provide data which will directly impact your eventual reimbursement.
Okay, that I don't understand. Explain it to our users. So I fill out the survey. How will it impact my reimbursement?
So that data is the data that we then present to this relative value scale update committee.
My individual data point, or do you roll it up?
We roll it all together. So we will tell them we had, and we usually don't get a ton, but we had 30 respondents. We had 40 respondents to this survey. And
is that good or bad? Is it embarrassing for us to have that many, or is it good?
I'd say it's typical of most medical specialties, but to me, it just shows that we are not involved in the process.
So you want a lot of respondents?
I want more. I want people to tell us what's really happening. I want good data.
Okay. So we get a survey. You want to know. You want a large response.
Correct.
Okay.
Absolutely.
So keep going through that example. You get the data.
So we get the data, put it all together. And so, for example, we look at it and say, okay, on average, our respondents say that this procedure takes 30 minutes and is this intense or this complex, and there's measurements of that. And it should have an RVU of something.
Well, I want it to go up. So I said up.
Right. Then that's fine. But you have to have the data to back that up.
What does that mean?
The data is the time.
But I'm
and
getting
the
faster. I'm a
intensity
slick
and
surgeon.
the complexity. Well, that's the deal. If they're faster,
So I can't have it both ways.
you cannot have it both ways.
Okay. And when I fill out the survey, do I pick how adept I am or my average surgery time? Or if you can't talk about it, I understand.
You pick what would be typical. And so your average surgery.
Oh, it's not my fastest tonsil would be 3
Definitely
minutes.
not
It's
your
a
fastest.
typical might take me 15.
Typical. What does this normally take you? And that's honest, good data that we're looking for.
Understood. Really appreciate it. So you go to the RUC committee. You represent us.
Correct.
And how often does it meet?
Meets 3 times a year.
And you go sit with the RUC committee.
Yep. So we present to this committee.
Is that AMA folks or CMS?
It's physicians. And so it's physicians from
But who convenes it?
the AMA convenes it. Physicians from a variety of different specialties. There is an otolaryngologist on that committee, but if we are presenting, that person is not allowed to speak.
Oh, so this is interesting. So we're presenting maxillary enterostomy to non-otolaryngologists.
Absolutely.
So how does that?
So that's part of the presentation. You have to explain to them what it is. You have to explain to them how intense, how complex it is. You have to explain to them why it's worth what you claim it is worth and how that fits into the overall fee schedule.
So let's pick a random case because I don't ever want to get you in trouble. Let's pick procedure Shah. It's called the Shah procedure.
Yes.
And 4 RVUs, you do a survey, and then you have 25th, 50th, 75th percentile of time.
Correct.
Or what we think it should be worth. Some people say 3, some people say 5 RVUs, some people say 7.
Sure.
Are we going to get to 7?
So what happens inevitably is if something is revalued or something, even if it's new, it's looked at very, very carefully. It's typically not on the higher end. If anything, it's typically on the lower end. But one of the jobs that then I have is to argue and try and craft arguments to explain why is it worth what we're claiming it's worth.
Exactly.
But what we need in order to do that is good data. We need time to back it up. We need intensity to back it up. And we can't have one without the other.
Understood. Thank you very much. So you do that, then it gets valued by that committee, and that's it?
That's not it. So that committee provides recommendations to CMS. And then CMS gives us an indication of what they're thinking, usually in the summer, and something called their proposed rule. Now, they may agree.
Generally, they do.
So generally they do. It used to be about 90%. Now it's getting in the orders of the 60s to 70%. And so...
And I bet you they don't raise it.
They would not raise it. If they change it, it's likely going down.
So I've got 2 groups coming at my knees.
Yes.
Okay.
Yeah. And then if they agree with it, great. It'll likely be then finalized in what's called the final rule, which comes out sometime in around November, and then is enacted into the fee schedule in January.
I would pound my fist on this table, but I might break the mics.
Right.
But this is probably the most important thing for the economic viability of your wife's practice and other practices.
So it's what I said earlier, because we are directly responsible for the reimbursement as physicians, as survey respondents. If physicians, survey respondents give good data, give adequate intensity and complexity, and again, appropriate.
Yeah.
You know,
But we complain all the time. I can't fix it. I can't do anything. We actually can answer the survey.
Fill out the survey. Let's not leave this in the hands of 30 people.
And be honest.
And absolutely always be honest.
So you're in academics.
Yes.
It's Jacqueline.
Yes.
Jacqueline, hello, we've helped your practice. How does this help academics?
Same way.
Well, explain it to me. I mean, what do you mean?
We all get reimbursed based on this whole system. So
how does it affect Pete Manis in your academic practice?
Well, in my academic practice,
you have RVU targets is what you mean?
RVU system, yeah. So I have RVU targets to meet. So if I do a procedure and the RVUs went down, well, I got to do something else to make up for that.
So smart guy like me might say it's even more important for academics.
You know what? I really do think it affects us all.
Wow.
There's no division here.
If let's take 30 survey respondents, are they usually private or academics or half and half? Who answers the surveys?
So we don't look at private versus academics, and it is de-identified.
So you have no idea.
You're anonymous, which is good.
Yeah. Your point is just answer the survey.
Answer the survey appropriately, honestly.
Okay. So you took me down this tangent, which was a 14-minute tangent because
I did this.
You did.
Okay.
Because I said, describe your roles. And you said RUC. And I said, let's define it.
Got it.
All right. So let's go back to your role. So what do you do for the Academy? You are our inaugural.
Industry consultant.
And then you're also?
Our on the board of directors.
Yep.
And then also our RUC advisor.
RUC advisor. So I've also then heard, so is there a committee that's RUC or what? Because you used to be.
Right. So there's a work group called the 3P, which is physician, payment, and policy. I previously
Is that physician, comma, payment, comma, policy, comma?
I haven't looked at the...
Or is it physician, payment, policy?
That's a great question.
All right, but 3P.
I'm going to look into that.
And is 3P RUC or what is 3P?
3P looks at all socioeconomic health policy issues. So we have a standing part of our agenda that discusses the CPT and RUC process. We have standing areas that look at advocacy, that look at private payer issues. All our position statements go through 3P prior to going on to our executive committee. So it looks at all of it.
And so you had a prior role there.
I was the previous chair of that. And Lance Manning is now the chair.
And you were chair of that, and that was your only role?
I was the coordinator originally the coordinator for health policy, then the coordinator for advocacy. The name changed a few times.
And now Lance Manning is our coordinator of advocacy and health policy.
Correct. I did 7 years of a 4-year term.
Yeah, understood. Thank you. Really, your contributions to the Academy and the economic viability of our members, awesome. Appreciate that. Thank you. So you mentioned CPT.
Yes.
So our audience now understands RUC.
Yep.
Relative Value
Scale Update Committee.
Relative Value Scale Update Committee, what we call RUC. Talk to us about CPT. How does the Academy get involved? What committees does it go through?
Sure. So, CPT process. CPT, we think of codes, procedure codes.
Yeah.
31255, whatever, 61782. Well, those have to be created.
Okay.
And so when there is a need to create them, and that can start at a committee level.
Sure.
That can start at an individual physician level, sometimes industry.
Absolutely, yeah. Or an academy level.
Yes.
We see a need for
or as an
neuromodulation for sleep or.
Yes. We look at that very closely. As a group, we have a separate CPT team that's led by Jim Lin.
Is that a committee or team?
It's a team, really.
So Dr. Jim Lin leads this committee.
Dr. Jim Lin leads this committee, and he will, in working with the interested parties, put together a CPT application. So an actual application for a new code.
And where does that go in the universe of healthcare?
So that is then submitted to a CPT panel, which again is run by the AMA.
Okay, so how often does that meet?
That meets 3 times a year as well.
All right, this gets very confusing.
It does.
All right, so the CPT panel, a code change application goes in, a opportunity for us to discuss a code. That happens 3 times a year. And Dr. Lin and I believe Dr. Lindsay,
correct,
partner.
Correct. Yes, Dr. Lin and Dr. Lindsay partner on this.
And do you have a partner on the RUC side?
I do. Brian Boyce.
Great. And what I mean by partner, Dr. Lindsay and Boyce are new to the team,
yes.
And we're trying to build that bench. You want to talk about building? Go ahead.
Well, that's what we need to do. We need more people involved in this. It takes a lot of time. It takes a lot of effort. You got to have some interest in it, and you got to want to do it. And so we need that. But we have that. We have an academy with
smart
motivated, interested people.
So Dr. Lindsay, new on the team, partners with Dr. Lin.
Yeah.
They go 3 times a year to a CPT AMA meeting.
Correct.
And then...
And similarly to what we do with the RUC, they present this code to that group, and that group will say yay or nay. And let's say they say yay, well, that then starts the clock on our job to actually get it valued.
Wait a minute, hold on. So they say yay.
Yeah.
And then what happens? Then
it gets turned over to us. Well, the CPT is the first part of the process.
Exactly. So then it needs to be valued.
It needs to be valued. And
that's back to you.
Yes.
Amazing. And is there a committee for that at the academy?
For the valuation?
No,
Or
for the CPT RUC, is there a separate committee? 'Cause
We
you
all-
mentioned 3P. Does 3P fall?
3P follows this. We sort of discuss it at 3P, and then our CPT team and our RUC team meet once a month to kind of go over all this stuff, make sure we each know, make sure the left hand knows what the right hand is doing.
Yeah. And I'm looking the audience in the eye. If it makes you feel any better, I'm at all those meetings. Okay. I'm not with you when you hit the road,
Right.
because I can't be really, but back home at all those meetings. So I'm learning and listening. These are the real experts, but thank you for having me there.
No, you're there. It's helpful.
So think hard. You weren't prepped on this. Your biggest RUC win, and now you said 7, maybe 8, 9 years you've been doing this. Are you allowed to talk about it, or you're not allowed?
I don't know. I wouldn't describe it as a win, and maybe some of the stuff that I'm kind of proudest of.
Okay, fine. I call them wins.
I know, but it's
All right.
win,
What are
loss,
you most proud of? If you can't talk on specific,
no, I
just
can.
be vague.
There were 2. There was an emergency tracheotomy code.
Okay, I'd increase that. Anyone else wants to answer that?
We got so our responses of surveys are divided into what did the 25th percentile say, what did the 50th percentile. We got the 75th percentile for that
Nice.
one,
And
which was great
why?
because it was scary. We made it appropriately scary to the panel members.
And how often do we do that, Pete? Once a year? Once?
I mean, this is not,
Liability's huge.
and you do that and you walk
Save a
away
life.
from it and you're kind of just like, oh my God, what did I do?
Yeah. So there's no RVUs on that. I mean, you saved some.
So yes, exactly. That's just,
When was that revalued, Pete? How long ago?
I'd have to look, maybe about 5-6 years ago or so. And then we redid the sinus surgery codes, all of them.
15 and 16?
And they went down, but honestly, they could have gone down a lot more.
Because people didn't answer the
Because
survey.
they didn't answer the survey.
Ah.
So while I was not happy that we lost, I was proud that it wasn't as bad as it could have been.
That's like the Mets game. I called you at a Mets game when you were at the finals.
Yeah.
Remember? And they lost, but not as bad as they could have.
You didn't really need to bring up the
Yeah, no, I thought I would,
They're
but
trying to throw me off.
yeah, it's a true story.
It's great.
So you averted what could have been a significant loss.
Well, all of us, we were just, it was, that would have been really bad. And we lessened the pain.
Are we respected when you go to Chicago or the sites in New York for those meetings?
Yeah.
Does otolaryngology get respect?
I'd like to think so.
No, for real.
No, really, I do. I think they realize that we are honest.
We're not gaming a system. We're just trying to.
We're not. We're honest people. We will tell it like it is. If we don't think something's worth something, we're not going to try and put up a lot of smoke and mirrors. And that goes a long way, because when you do care about something, when you do need something, then you're the honest broker.
So that's the structure of how a code and valuation runs through. Fair?
Correct.
I think, do we miss anything?
No.
So you mentioned that a code was reevaluated 2015 and 16. That was FES. And we said that's like yesterday. It's very recent. What are some other big revaluations that have happened 2011, 12, or anything in that time that our members should really know about?
Well, there was actually even creation of codes. A lot of in-office laryngoscopy codes, like with interventions.
When did that happen?
That was a big family. Probably about 2012, 2013.
So they due up to be renewed or no?
Not necessarily, because they may not hit one of those screens. And so they may just kind of exist as they are. So
Are the screens, is it too complicated to list what a screen?
they're very complicated.
Oh, and they use algorithms.
They use weird algorithms that say, if it's used 50,000 more times, and it has an RVU value of this, and it's a lot of things.
So let's make it all about Jacqueline.
She's gonna love this.
She's gonna love this, yeah. So what should Jacqueline take home the nice 20-minute discussion we've had? What are the big points you want members to know?
I really want members to know what role they can play in this process.
And that
role
is?
they should play in this process, which is
Look them right in the eye.
fill out the surveys. We send you a survey. Please, please, please fill it out. We need you to. And if you think it doesn't matter, it actually completely directly matters and completely directly affects.
But the rules are tricky. I can't be picking up the phone, calling my friend saying, fill out the survey. That's illegal. We're telling you now, when you get those surveys, fill them out.
Fill them out honestly, fill them out fairly.
So that's one thing they can do. What else can they do?
There's a lot of issues with physician payment and Medicare reimbursement and things like that. Get involved. And what does that mean? That's such a silly thing to say, but honestly, talk to your legislators. Come to the Hill.
Or talk to us.
Learn how to do it.
Or talk to us. Tell us
so
when
that
you
we
have
can
an issue.
pass that along.
Right? We have a great team. Pass it along to our team, right?
Yes.
You want to talk about that? They give us queries all the time, member inquiries.
Our health policy team that works at the Academy, they're fantastic. They care about what's going on with our members, and they are there to help us. And so if you're having issues, they want to know about it. We may not be able to fix every issue, but one of the things it helps us do is identify trends, because we need to identify those trends, because then that allows us to act on these things more
Before
globally.
they spiral and go too far. Yeah.
Correct.
Just a couple minutes on your new role. Very grateful to you to be our industry consultant. We're unique as an organization. We have a surgeon CEO, which is me. So I have some competence and aptitude, but it's awesome having you as an industry consultant. Do you want to talk about the role? You've disclosed all your conflicts. I don't care about that, but talk about your role and what you do. We've had several meetings here and you've been invaluable for members. Talk about your role.
Yeah, we've been working a lot with industry. One of the things we realized, honestly, you've realized, and through discussions, we've, come to these conclusions that we need to partner with industry. We need innovation. We need to be able to get technology and treatments into the hands of our members so we can use it for patients. And that's a lot. There's a lot that goes into that. And we as an organization need to help foster that. And so there's a lot of relationships that we can develop with our industry partners, things that we can help them with in order to do that. So that's the 50,000 foot view of what I'm trying to do in this new role.
And you also are helping with market access, reimbursement, but reimbursement, how do we ethically partner with them to make sure that we win for our patients? Setting up the right codes so our providers use them to get technology to patients.
Well, that's the whole game. And honestly, our industry partners, they get it. They're ethical. We might have disagreements with them, so we'll be honest with them.
They're good people. They're our neighbors.
Yeah.
They're our friends.
They're honest with us, and we're honest with them.
Yes. I really do think you're one of the most important people in the Academy and as a member because of your role, you and Dr. Lynn and Lance Manning and all your committees. All dozens of you that work hard day in and day out for the coding to make sure that our practices stay in tune.
That's nice of you to say.
Thank you for that. So we're about to wrap up. I'll tell you, I'm a huge Red Sox fan. Was it the 86 World Series, Red Sox and Mets, when it went underneath Bill Buckner's feet?
Sure.
And the Mets won?
Oh, well, that was Game 6.
Did they win?
They won Game 6, but then they had to come back and win Game 7.
I don't remember. Did they?
Oh, yeah.
I don't remember. I was a Red Sox fan. I forgot it.
Remember.
No, I don't remember. I just forgot it.
I was 10 years old. I remember it.
But I know Buckner lost it.
Should have won Game 7.
Thank you very much, Pete, for everything you do for our members. Incredibly awesome. You're going to be attending a innovation course, taking a week from your life to help us learn how to be innovators. So I just love the work you're doing.
I can't wait. This is going to be great. I'm loving this.
Awesome. Thank you so much, Dr. Manis.
Thank you.
We hope today's episode sparked some fresh ideas. If it resonated with you, please subscribe and share it with friends. Have thoughts or suggestions? Use the feedback form in the show notes. We'd love to hear from you. And don't forget to follow us on social media for highlights, behind-the-scenes content, and updates. Thanks for listening. See you next time.